Welcome to the audio digest of the American Journal of Psychiatry. This is Dr. Susan Schultz with highlights from our September issue. Please note that the full text of all articles may be viewed online at hap.psychiatryonline.org, including all author affiliations and disclosures of competing interests. This month we have 3 features on children and adolescents. The first one reviews the treatment of depression in preschool children, and another examines the relationship between sudden death and the use of stimulant medications in youth. We'll also highlight a study of long-term benefits from a short-term quality improvement intervention for depressed youth in primary care. The next article looks at depression at the molecular level. Overlap between 2 species in altered gene expression in the anterior cingulate cortex and amygdala was used to identify genes that may be relevant to major depression. From there, we'll turn to the role of genetics in schizophrenia. 2 national registers in Finland were linked in order to study the interaction between family history and prenatal exposure to infection in the causation of schizophrenia. And our final article reports that substance use disorders in an African American cohort were associated with childhood trauma, but not with African genetic heritage. We'll start with our Treatment in Psychiatry article about early childhood depression. Joan Luby presents the case of a girl referred to as Jane, who is 4 years, 8 months old. Her parents are concerned about her extreme irritability, social withdrawal, negativity, and decreased appetite. When observed while playing, Jane displayed age-appropriate representational play, as well as intact motor and language skills. However, she was preoccupied with negative play themes and pessimistic thoughts. She was also quiet and withdrawn and didn't display the exuberance expected at her age. Preschool depression is more often characterized by age-adjusted manifestations of the typical depressive symptoms rather than masked symptoms such as somatic complaints or aggression. However, caregivers may not report symptoms such as changes in play or sleep, or may unwittingly accommodate these behaviors and not regard them as significant. Therefore, the clinician should make detailed inquiries into all aspects of a young child's functioning. Diagnosis of preschool depression is challenging because common symptoms such as irritability and even sadness are relatively nonspecific. In one empirical study, anhedonia, excessive guilt, extreme fatigue, and diminished cognitive abilities were the most useful markers of preschool depression. Adding to the confusion is frequent comorbidity with the more common behavioral disorders, such as attention deficit hyperactivity disorder. These disorders are more often obvious, increasing the risk that they'll overshadow co-occurring depression. Once the diagnosis of depression is established, clinicians have little empirical evidence to guide treatment. Except for a few case reports, no data are available on the safety or efficacy of antidepressant medication in any form of preschool psychopathology. Based on this and the finding that younger children may be at greater risk for activation from selective serotonin reuptake inhibitors, the use of antidepressants is not a first-line or even second-line treatment for early childhood depression. Psychotherapies that are appropriate for young children focus on the child and caregiver together. One such treatment is parent-child interaction therapy. A depression module has been created that focuses on enhancing emotional development. It uses a well-validated treatment that has proven efficacy for preschool disruptive disorders. It enhances emotional skills and also targets the child's ability to regulate emotion by enhancing the caregiver's capacity to serve as an external emotion regulator. The treatment is manualized and consists of 14 weekly sessions. The caregiver interacts with the child and the therapist observes through a one-way mirror. A microphone and earbud are used to allow the therapist to coach the caregiver. Between sessions, homework is assigned. SSRI antidepressants should be considered only in cases of very severe symptoms and after the failure of adequate trials of developmentally appropriate psychotherapies. In these cases, it's critical to explain to the parents or caregivers that the treatment is experimental and that its efficacy and effects on growth and development remain unknown. Very small doses and slow titration should be used under close observation. High vigilance by parents and the clinician for activating side effects should be emphasized. This intervention should be applied only in highly reliable families who can fully comply with this treatment plan. Now we'll turn to the case control study by Madeline Gould and colleagues that showed an association between sudden death and use of stimulant medications in youth. There have been reports of sudden death among children and adolescents receiving stimulants for attention deficit hyperactivity disorder, and these have raised concerns about the safety of these drugs. However, sudden death in this age group is rare, and so a matched case control design was employed. Cases of sudden unexplained death were identified by 3 ICD codes representing sudden death with unknown cause, other unknown and unspecified causes, and cardiac dysrhythmia. Individuals 17 through 19 years of age with these codes were identified from mortality data in state vital statistics across the United States for the years 1985 to 1996. Deaths were excluded if there were coexisting physical disorders known or suspected to be associated with sudden death. The comparison group consisted of youth who died as passengers in motor vehicle accidents. These subjects were individually matched to those with unexplained deaths by age, gender, and the sources of information. Each matched pair was unique. An individual accident victim was matched to only one case of sudden unexplained death. The primary exposure variable was evidence of stimulant use prior to death. This was based on the presence of amphetamine, dextroamphetamine, methamphetamine, methylphenidate, or a derivative as noted by informants or in medical examiner records, toxicology findings, or death certificates. Parents were approached by a letter describing the purpose of the study. They were asked to complete a survey including items about their child's medical history and medications taken at the time of death. A history of sudden death among relatives was also assessed. Medical examiner records and toxicology findings were also used to identify medications. Medical examiner reports could include findings based on informants or toxicology tests, as well as autopsy reports. The jurisdictions varied considerably in the detection threshold at which a blood or urine stimulant level was deemed positive. From the 564 young people whose deaths were listed as being due to a cardiac dysrhythmia or unknown causes, 10 were identified as using stimulants. This represents 1.8%, whereas the rate for the accident victims was 0.4%. The odds ratio derived from exact logistic regression was 7.4. In each of the cases of unexplained death associated with stimulants, the drug detected was methylphenidate. Of the 2 accident victims who used stimulants, 1 appeared likely to have used stimulants illicitly. The findings are discussed in an editorial by Benedetto Vitiello and Kenneth Tobin. They describe the report by Gould and colleagues as the first methodologically rigorous study to identify a link between therapeutic use of stimulant medication and sudden unexplained death in children without demonstrated heart abnormalities. The rarity of sudden unexplained death makes randomized prospective studies impractical. Although case control studies aren't perfect, they're probably the highest level of evidence that can be obtained about this problem. Also, the investigators went to great lengths to reduce possible sources of bias. They used multiple types of information to confirm stimulant use and conducted a series of sensitivity analyses, the results of which did not change the main conclusion. However, important confounders may remain. For example, the methods didn't allow the investigators to learn whether the risk for sudden unexplained death was increased by ADHD itself, independent of stimulants. This is a plausible hypothesis given the association between ADHD and high-risk behaviors such as substance abuse. Although a known history or post-mortem toxicology evidence of substance abuse was a reason for exclusion from the study, the sensitivity of these screening procedures is not perfect. Other drugs could have been ingested or inhaled. Furthermore, the parents of 40% of the eligible cases could not be found or would not provide information. There's also a risk of inequality in the effort to search for medical explanations in the two groups, so that stimulant use might have been missed in the comparison subjects who died in motor vehicle accidents. The report by Gould and colleagues should underscore that stimulants are not without risk, and that their therapeutic use requires careful diagnostic assessment, diligent safety screening, and ongoing monitoring. More research is required to improve the sensitivity of screening for heart conditions that increase the risk for sudden death. Unfortunately, this report can't assist in resolving the debate over the value of pre-treatment ECG screening because ECGs were not systematically obtained for these individuals. An ECG can detect heart conduction disorders, such as QT prolongation or Wolff-Parkinson-White syndrome, which increase the risk for sudden unexplained death but are not identifiable post-mortem. In addition, the sympathomimetic activity of stimulants provides biological plausibility for cardiovascular effects. However, it's equally clear that sudden unexplained death is rare. This is only the first such study. It relies on small numbers, and it's not possible to quantify the risk beyond estimating that it's very small. A full estimate of the risk-benefit ratio of ADHD treatment can't be properly conducted at the population level because sudden unexplained death is rare, and we lack long-term data on the effectiveness of these medications for reducing other adverse health outcomes. ADHD itself has been associated with accidents, medical hospitalizations, unsafe sex practices, antisocial behavior, and substance abuse. Next, we'll highlight a study by Joan Rosenbaum, Asarno, and colleagues that showed long-term benefits of short-term quality improvement intervention for depressed youth in primary care. The intervention was designed to improve access to cognitive behavioral therapy and antidepressant medication in primary care, since that's a major point of health service contact for children and adolescents. 6 study sites were selected to include the public sector, managed care, and academic health programs. The intervention lasted 6 months, and the participants were followed up at 6, 12, and 18 months. This analysis examines outcomes at 18 months for more than 300 youths. 42% had a diagnosis of major depression, and 57% had subsyndromal depression. Patients in the intervention group were offered a visit with a care manager that emphasized evaluation, education about treatment options, and clarification of preferences. The care managers were trained in manualized CBT for depression, and the patients and providers were given a choice of CBT, medication, referral, and follow-up. A treatment plan was developed, and the care managers followed the patient for 6 months, supported the primary care provider, and delivered the CBT. The intervention was compared with treatment as usual, which was enhanced by providing the primary care physicians with 1 to 2 hours of training and educational materials. The training emphasized evaluation strategies, depressive symptoms, common comorbid disorders and complicating conditions, and treatment methods, particularly medication. The study began before the controversies about a risk of suicidality in youths taking antidepressants. The primary outcome variable was the presence or absence of severe depression, which was defined as a score of 24 or higher on the Center for Epidemiological Studies Depression scale. The intervention group had a significantly lower rate of severe depression at 6 months than the group that received treatment as usual. The difference at 18 months did not reach statistical significance. The study did not have sufficient statistical power to assess outcomes of suicide attempts, but the intervention did not have a statistically significant effect on the rate of suicidal ideation or suicide attempts. At 6 months, the rates of suicide attempts had declined more than 50% in both groups. Recovery was defined as a depression score less than 24. A survival analysis showed that the estimated probability of initial recovery at 6 months was roughly 10 percentage points higher in the intervention group. However, there was no difference at 18 months. Both groups had a 90% cumulative probability of recovery. However, the mean time to recovery was 27 days less for the intervention group than for the treatment as usual group. A path analysis also demonstrated that the effect of the intervention on the outcomes at 18 months was not significant. However, it did show indirect effects. The intervention had a significant effect on severe depression at 6 months, which influenced severe depression at 12 months, which in turn affected depression at 18 months. Now we'll explore the underpinnings of depression. A molecular signature of depression in the amygdala is reported by Etienne Sibylle and colleagues. They examined postmortem tissue in the amygdala and the anterior cingulate cortex, since these are critical components of a corticolimbic circuit of mood regulation that's affected in major depression. Several biological systems have been implicated in the molecular pathology of depression by means of large-scale gene arrays, but there hasn't been a consensus. Possible reasons for this include differences in brain areas investigated, different analytical approaches, and substantial clinical heterogeneity. This study reduced clinical variation by restricting the cohort to men with familial major depressive disorder. They were compared to subjects without depression who were matched for age, sex, and race. Large-scale gene expression was monitored in postmortem tissue from the anterior cingulate cortex and amygdala of 16 pairs of subjects. Then, differences in transcript expression between the depressed and comparison men were identified. Comparable data were also obtained from mice by subjecting the mice to various mild, unpredictable stressors for 7 weeks. This process induces a depressive-like syndrome in mice and is reversed by chronic administration of antidepressants. On day 14, the mice were divided into 3 groups and began receiving fluoxetine, a corticotropin-releasing factor 1 antagonist, or vehicle. At the end of 7 weeks, microarray data were gathered from the cingulate cortex and amygdala. Results from the men with major depression were compared with those from the mice. First, any genes potentially affected in the depressed men were flagged. Then similar changes for orthologous probe sets in the mice were identified. The assumption was that human depression-related changes would manifest as weak effects, but that the conservation of the changes across species would provide independent lines of validation. Abnormal expression of nearly 200 gene transcripts was identified in the amygdala of the depressed men. Expression levels in the mice were available for over 100 ortholog probe sets, and changes in these probe sets were significantly correlated with the human depression-related changes. Conversely, nearly 300 altered transcripts were identified in the amygdala of the mice subjected to unpredictable chronic mild stress, and more than 200 of them had identified human orthologs. These also displayed a significant correlation between species. In addition, the correlations between humans and mice disappeared after antidepressant treatments in the mice. The correlations were specific to the amygdala and weren't seen in the anterior cingulate gyrus. The depressed human subjects varied in the correlation of these results with those in mice. Greater severity of depression appeared to be associated with a stronger positive correlation between the species. The correlated transcripts represented 38 genes with changes in the same direction in both species, and antidepressant treatment reversed the changes for 32 of these genes in the mice. Pairwise correlations of gene expression indicated that 32 identified genes belong to a naturally occurring, cohesive functional network that includes glial and neuronal components. 2 distinct cellular phenotypes were identified: downregulated oligodendrocyte structure and function, and upregulated neuronal function. Genes with suggested neuronal enrichment of transcripts were related to cellular maturation and synaptic development, neurotransmission and signaling, and interactions between cells and the matrix. Genetic background was also an element in the study by Mary Clark and colleagues. They report evidence for an interaction between familial liability and prenatal exposure to infection in the causation of schizophrenia. Previous findings on how prenatal exposure to infection affects the risk of schizophrenia have been inconsistent. This raised the question of whether another risk factor for schizophrenia is involved, such as the genetic liability to psychosis. A large Finnish cohort provided a means to study the effect of family history and prenatal exposure to pyelonephritis on the subsequent development of schizophrenia. Pyelonephritis is an infection of the upper urinary tract, and it occurs in 1 to 2% of pregnant women. Most pregnant women with the infection are admitted to the hospital. Therefore, Clark and colleagues linked records between population and hospital discharge registers in order to model the synergistic effects of prenatal infection exposure and family history of psychosis. The base study population comprised all individuals born in Helsinki between 1947 and 1990. Individuals whose mothers were hospitalized for acute pyelonephritis in pregnancy were identified, along with a comparison group of siblings who were not exposed in utero to pyelonephritis. Psychiatric outcomes in adulthood and family history of psychosis were determined from the Finnish Hospital Discharge Register. Psychiatric diagnoses were ascertained for the exposed cases, the sibling comparison group, and the parents. To examine the synergistic effect of exposure to infection and genetic liability to psychosis, the data were stratified on the basis of family history of psychotic disorder. The effect of prenatal infection was then examined separately in the groups with positive and negative family histories. Close to 10,000 individuals were in gestation when their mothers were hospitalized for pyelonephritis. Nearly 14,000 siblings were also born during the same years and were not exposed to maternal pyelonephritis while in utero. 6% of the total group had a positive family history of psychotic disorder. Exposure to infection did not significantly increase the risk of developing either schizophrenia or broadly defined psychotic disorder. Nevertheless, the risk of developing schizophrenia was almost 50% higher in the exposed group compared to the unexposed group. The timing of the infection during gestation did not significantly affect the risk of schizophrenia, but there were only 2 patients exposed in the first trimester, and so no conclusion can be made. When separate analyses were conducted for individuals with and without a family history of psychotic disorder, it was discovered that the effect of prenatal exposure to pyelonephritis was significantly greater for those with a positive family history of psychosis. The difference in risk for schizophrenia between those exposed and those not exposed to prenatal infection in the genetically vulnerable group was 5 times as great as the difference in risk among those who were not genetically vulnerable. The amount of synergism between the 2 risk factors was estimated by calculating the risk percentages for each risk stratum: no infection and no family history, infection only, family history only, and infection plus family history. These indicated that 38 to 46% of the individuals who developed schizophrenia in this sample did so as a result of the synergistic action of prenatal exposure to infection and positive family history of psychosis. Our final article examines the influence of African ancestry on substance dependence. Francesca Ducci and colleagues found an association of substance use disorders with childhood trauma, but not African genetic heritage, in an African American cohort. The study was made possible by the recent availability of reference populations representing worldwide genetic diversity and of ancestry informative markers. These genetic markers are polymorphisms that exhibit substantially different frequencies between populations from different geographical regions. They've enabled researchers to elucidate a worldwide pattern of ethnic factor structure and to quantify individual ancestry. Self-reported ethnicity is generally a suitable proxy for genetically inferred ancestry, but it's generally a binary measure. Ancestry informative markers are available to compare gradations of genetic ancestry. Racial differences in drug abuse and its consequences have long been described, but the relative importance of genetic and social factors has been ambiguous. The aim of this study was to evaluate whether genetic ancestry contributes to differences between individuals in the vulnerability to addiction among more than 800 self-identified African Americans. Half had diagnoses of substance dependence, and Ducci and colleagues evaluated the relationship between the degree of African ancestry and the risk of cocaine, opiate, and alcohol addiction. The authors also tested whether African ancestry correlated with environmental risk factors that moderate the risk for substance use disorders, abuse or neglect during childhood, and socioeconomic status. The African American individuals with substance dependence were patients in a VA treatment program. They'd been abstinent for at least 2 weeks as judged by urine tests and breath analysis. They were diagnosed with substance dependence on cocaine, opiates, alcohol, or a combination, and comorbidity was common. The comparison subjects were recruited from African American diabetic outpatients in an ophthalmology clinic and from blood bank volunteers. The Childhood Trauma Questionnaire provides scores for childhood physical abuse, emotional abuse, sexual abuse, physical neglect, and emotional neglect. Characteristics of the participants' neighborhoods were ascertained by mapping the subjects' addresses to the tracts in the 2000 census. Address matching was available for more than 200 of the patients with cocaine addiction. For these patients, it was possible to obtain neighborhood statistics on median household income, per capita income, percentage of families above the poverty level, percent of persons older than 25 years with a high school diploma, percent with a bachelor's degree, and percent of housing units occupied by the owner. All of these variables were converted into categorical variables by using a median split. To characterize the ethnic origin of each individual, 186 ancestry informative markers were selected. Each one was a genetically independent single nucleotide polymorphism that differed in allele frequency by at least 70% and tenfold between at least 2 populations from among Europeans, Africans, and Asians. The markers were selected to be equally informative for these 3 continental populations. They were also genotyped in 51 worldwide populations represented in the cell line panel of a large reference collection. The proportions of 7 ethnic factors were estimated. African ancestry accounted for 79% of the participants' genetic heritage. Europe accounted for 7%, and the Middle East for 5%, and Central Asia for 6%. The African American individuals varied widely in the degree of African ancestry, and the proportions were significantly lower in the patients with alcohol, cocaine, or opiate dependence than in the comparison subjects. The average differences were small, however, ranging from 5% for opiate dependence to 3% for cocaine dependence. Exposure to abuse or neglect during childhood was strongly associated with addiction later in life. The score on each of the 5 subscales of the Childhood Trauma Questionnaire was associated with each substance use disorder. The highest odds ratio was for physical abuse among those with cocaine addiction, which suggested that the vulnerability to cocaine dependence was nearly 7 times as great for individuals with a childhood history of physical abuse compared to those without physical abuse. The percentage of subjects suffering from substance dependence tended to increase in stepwise fashion with the number of types of childhood abuse and neglect. This stepwise effect of trauma was more evident for cocaine and opiates than for alcohol. The levels of African ancestry were similar in the groups with and without exposure to childhood abuse or neglect. For the patients with cocaine addiction whose addresses were matched to census tracts, those residing in neighborhoods with lower socioeconomic status tended to have higher degrees of African ancestry. These differences reached statistical significance for 3 measures of socioeconomic status: lower per capita income, lower median household income, and lower percentage of residents older than 25 years with a high school diploma. This concludes the audio highlights of the September issue of the American Journal of Psychiatry. We invite you to our website, ajp.psychiatryonline.org, for the full text of these and other articles. We also welcome comments regarding this audio. They can be emailed to Jane Weaver. Her email address is jweaver@psych.org. Next month, we'll highlight Bipolar II postpartum depression, a collaborative model for bipolar disorder to increase evidence-based care over 3 years, and the influence of neighborhood environment on outcomes for patients with dual diagnoses. We hope that you'll join us again. Thank you.